Hello everyone, my name is Yossof Abouelnagah. I'm a postdoctoral research fellow at Beth Israel Deaconess Medical Center, Harvard Medical School. And today we will explore intraoperative neuromonitoring known as IONM and its role in guiding cryoablations in tumor therapy. Here is our agenda for today. We will start with a background on the application of intraoperative neuromonitoring. Then we will walk through the study design, have a couple of case presentations, and finally we will wrap up with the key takeaways. As we all know, CT is essential for guiding cryoablations, but it definitely has some limitations. First, CT clearly shows the ice ball, but this corresponds only to the 0 degrees Celsius boundary, not the actual lethal temperature zone. So while we see where freezing has occurred, we don't know how cold it is within different regions. Second, CT cannot distinguish between sublethal, therapeutic, and excessively cold zones within the ice ball. This means we cannot determine whether a nearby nerve is safe, reversibly injured, or at risk of permanent damage. And more importantly, local factors such as an adjacent blood vessel acting as a heat buffer can significantly alter the temperature distribution, making the actual thermal effect very unpredictable. Generally, nerve injury is divided into 3 categories, depending on the temperature they got exposed to. First, neurotomesis, which is the permanent transection of a nerve, and it happens below -100 degrees Celsius. Then, we have axontomesis, which is a reversible axonal degeneration, also well known as Wallerian or Wallerian degeneration, and it happens between -20 and -100 degrees Celsius. Lastly, above -20 degrees Celsius, it's too warm to make a therapeutic effect, yet it can also cause neuropraxia. That's why protecting the nerves is the core to safe practice. Moving on, let's talk about the role of intraoperative neuromonitoring. As we know, passive thermal protection techniques like hydrodissection, pneumodissection, and hydroconvection have been used for years, but intraoperative neuromonitoring offers a real-time functional approach as it monitors motor evoked potentials and somatosensory evoked potentials to detect conduction changes as soon as they occur. Significant changes is defined as a greater than or equal 30% reduction in motor evoked potentials amplitude or greater than or equal 50% reduction in the somatosensory evoked potentials. Thus, these alarms alert us before permanent injury occurs, allowing us to adjust or stop the ablation. This is the study we're going to be discussing today. It's titled as Utility of Intraoperative Neuromonitoring to Protect Against Adjacent Nerve Injury in Musculoskeletal and Lymph Nodal Cryoablation, and it was published in the JVIR in October 2024. It's a retrospective single-center study spanning almost 4 years. 29 patients were included whom underwent 33 procedures. Hydrodissection was done in 59% of the procedures, which basically is the injection of fluid to create a protective space between the target lesion and the nearby critical structures. And this is our first case of today. It's a cryoablation and seminoplasty of a 3.2 centimeters metastatic renal cell carcinoma lesion in the left acetabulum with intraoperative neuromonitoring of the obturator nerve shown by the red arrow. In the image A, pre-procedural enhanced imaging demonstrated the 3 centimeter renal cell carcinoma in the left acetabular region, and in image B, intraprocedural CT image with the patient in a prone position demonstrated the placement of the cryoablation probe and its proximity to the obturator nerve, also shown in the red arrow. Final CT image demonstrated the cementoplasty after the ablation. In the motor evoked potential, the tracing of the left obturator nerve demonstrated greater than 70% reduction of the amplitude after 5 minutes of ablation, which is shown by the red arrow in the tracing, in the yellow tracing to be exact. Complete recovery of the amplitude after 5 minutes, which is shown here by the green arrow, and the initiation of a second freeze cycle truncated to the point prior to the detected significant motor evoked potential reduction. And final motor evoked potential demonstrated stable amplitude, and the patient had no deficits upon extubation. Our second case is a 50-year-old man with metastatic multiple myeloma presented with progressive 6 to 9 out of 10 right hip pain with multifocal lesions in the right acetabulum. Subcutaneous electrodes were placed on the scalp overlying the primary motor cortex for motor evoked potential monitoring of major muscle groups in the right lower extremity. Here we can see in the pre-procedural CT demonstrated multifocal lesions shown with the red arrows in the right acetabulum. An intraoperative CT demonstrated the hydrodissection of the sciatic nerve in the red arrow in image C away from the targeted ablation site. Motor evoked potential tracings of the right tibialis anterior muscle shown on the left side of the tracing and right abductor hallucis muscle on the right side of the tracing demonstrated a greater than 50% amplitude reduction shown by the red arrows at 3 minutes from the baseline, which is shown by the green arrows. The freezing cycle was promptly terminated and amplitude did not actually recover to baseline after 10 minutes. Hence, no further freeze cycle were attempted. Following the decision to not attempt the additional freeze cycle, the balloon-assisted cementoplasty shown in the red arrow on the right side picture was performed, and post-procedurally, patient reported right lower extremity weakness. But it did not impact the mobility, and he recovered to baseline within 1 week. Patient's right hip pain surprisingly improved to 0 to 3 out of 10 at 1 week follow-up. The protocol followed a consistent algorithm, starting with monitoring the motor evoked potentials continuously, where 15 out of the 33 patients underwent the whole procedure with stable tracing with no neurological sequelae. But if motor evoked potentials amplitude drop greater than 30%, stop the freeze immediately and initiate an active thaw, and if necessary, reposition the probe or adjust the power. Once signals recover, consider resuming with a truncated freeze, and if signals do not recover, terminate the cryoablation and switch to an alternative therapy, for example, cementoplasty. This workflow prioritizes the nerve safety while preserving the oncologic efficacy. Taking a deeper look into these outcomes, significant motor evoked potential reductions occurred in almost half of the patients, and the mean time to the first detection was 5.2 minutes, and most of these cases the reductions occurred in the first freeze cycle. After stopping the freeze and actively thawing, motor evoked potentials recovered to baseline in 3/4 of these cases. And when signals recovered, additional truncated freeze cycles were attempted, achieving a full treatment in many procedures. Importantly, only 15% of all procedures resulted in immediate neurologic deficits, even though all patients fully recovered by 12 months. Limitations include the retrospective single-center design and small sample size. There was also no control group, and the intraoperative neuromonitoring requires specialized equipment and expertise. Somatosensory evoked potentials were unreliable when cryoablation probes were active. So, motor evoked potentials are the more sensitive modality. Despite these limitations, the study shows that intraoperative neuromonitoring can prevent irreversible cryoneurolysis, allowing safe completion of the ablation in most patients. Hydrodissection was performed in nearly 60% of the procedures, showing that combining passive and active methods provides robust protection. Looking ahead, implementing standardized protocols and running cost-effect analysis may be of benefit. Lastly, to conclude, intraoperative neuromonitoring transforms cryoablation from an anatomy-guided procedure into a function-guided therapy. Real-time feedback allows us to detect neuropraxia early, adjust our techniques, and continue treatment without harming the patient. When motor evoked potentials recover, treatment can proceed safely. When they do not recover, we adapt our approach, preserving the nerve function while still controlling the tumor. As cryoablation expands to more complex anatomical sites, integrating intraoperative neuromonitoring and complementary techniques like hydrodissection will be essential for delivering safe, effective care. This brings us to the end. Thank you all for your attention. I hope you enjoyed today's topic. I look forward to meeting you again in the future sessions with Academy of Online Radiology Education. Thank you and see you next time.